All right, good evening. Thank you for coming. I'm just going to wait another minute or so to see if anyone else hops on, but we'll get started shortly. Thank you. All right, hi everyone. Thank you for coming tonight. I figured since we have a good turnout at the moment, I'm just going to get started with the presentation. So for those of you who may not know me, my name is Sam. I'm one of the pharmacy residents, and today I'm going to be doing my CE on the management of malignant hyperthermia. So just before we get started, I have no financial interests or affiliations with any organizations, and any brand names that will be used throughout the presentation are just for ease of identification purposes, as well as one of the medications that I'll be talking about, I'll refer to the brand name because that's what we have here at Stony Brook. So just to make it more relevant to what our practice will be as pharmacists here. So our objectives for today are to define malignant hyperthermia, to identify patient physiology and medications that are associated with malignant hyperthermia, to recognize the clinical presentation of malignant hyperthermia, and to lastly outline management of patients with malignant hyperthermia. So first we're going to start off with what is MH. So MH is a rare inherited musculoskeletal syndrome. It's an autosomal dominant disease. So if one of your parents has the abnormal gene that is associated with malignant hyperthermia, the child would have a 50% chance of also having it. So MH occurs when there's functionally altered calcium release that causes dysfunction of the intracellular calcium homeostasis, as well as uncontrolled calcium release from the sarcoplasmic reticulum. This excessive calcium will lead to a fatal hypermetabolic state, which is the MH crisis. It's triggered by exposure to volatile anesthetic gases, as well as succinylcholine, which is one of our depolarizing muscle relaxants that's commonly used in intubation situations. So I'll be talking more about these in depth in a little bit in the presentation. So again, just one thing to really focus on with MH is that the underlying physiology is due to this abnormal calcium homeostasis, and this will result in skeletal muscle hypermetabolism as well as activation of the muscles. So this leads to our clinical features that I'll talk about a little later on, and these can lead to severe complications with the progression of malignant hyperthermia. So just to kind of put a schematic on here to help us understand the pathophys behind MH. So as you can see, this is kind of just a snapshot of the sarcoplasmic reticulum, just zoomed in a little bit. And so the main problem with MH is the dysregulation in intracellular calcium homeostasis, as I mentioned before. So as you can see in this picture, calcium is released from the sarcoplasmic reticulum in quantities that are much larger than normal. And this will cause an increase in calcium concentration, which causes our actin and myosin to continually contract and will lead to sustained muscular activity and muscle cell metabolism. And through this metabolism, we'll get oxygen consumption and carbon dioxide production, which will lead to heat production, which leads to hypothermia. And this can eventually lead to the cells running out of energy, breaking down, and actually spilling and releasing their contents into the bloodstream. And when this occurs, this is when we have the downstream effects of malignant hyperthermia, which again, I'll get into a little further on, but just so we have a background of what is happening in this syndrome. Now, this is a very rare syndrome. So who is prone to getting this? So we see the most incidence in children and young adults, specifically in young males. So there was a prevalence study done in New York State in the early 2000s that estimated the prevalence of MH to be 2.5 to 4.5 times higher in males than females. But the problem with this is since MH is a genetic abnormality, patients who are predisposed to MH have no daily symptoms. So it makes the true incidence of MH unknown. So because of this, we have to look at a lot of different epidemiological studies to kind of dive into the chances of patients being at risk for an MH crisis. So there's a study that revealed that MH complicates approximately 1 in 100,000 surgeries in our adult population and approximately 1 in 30,000 surgeries in our children population. So even though this prevalence is very rare, the prevalence of the genetic mutation that predisposes our patients to malignant hyperthermia is actually much higher. So this is approximately 1 in 2,000 patients are genetically susceptible to MH. And on the next few slides, I'm going to talk about the certain receptors and genes that are affected in this genetic abnormality. Something to note, though, is that even if patients are genetically susceptible to getting malignant hyperthermia after exposure to certain anesthetics, it does not mean every time they are exposed to said anesthetics, they will have a malignant hyperthermic crisis. It's just a susceptible experience that they may have. So to kind of understand what is happening in malignant hyperthermia, we have to understand what will normally happen in our bodies. So this is when we're going to really focus on our intracellular calcium and its role in muscle contraction. So calcium is a very important messenger for signal transduction and is essential for the cellular process that's known as excitation contraction coupling, or EC coupling. So EC coupling describes a series of events that happens from the production of our electrical impulses to the actual contraction of the muscles in our heart and in our extremities. So this process is of vital importance because it actually allows our hearts to beat and our muscles to move, and therefore let us carry out all of our daily activities. So the main source of intracellular calcium is in the sarcoplasmic reticulum in our striated muscles and the endoplasmic reticulum in our other cell types. So because MH is mostly with muscle rigidity in our extremities, we're just going to be focusing on the sarcoplasmic reticulum. And one of the major calcium release channels that's located in the sarcoplasmic reticulum is called the ryanodine receptors. And these are the receptors that are directly affected in malignant hyperthermia. So our ryanodine receptors are located in the sarcoplasmic reticulum and our endoplasmic reticulum. And again, these are responsible for the release of calcium from the intracellular stores. So our R1 receptors are located on our skeletal muscles, while our ryanodine 2 or R2 receptors are on our cardiac muscles. And these are crucial for that EC coupling I mentioned on the last slide in these respective places. So when the ryanodine receptors are activated, the action potential travels to the transverse tubules, which therefore results in our calcium release. And due to this increase in cytoplasmic calcium, this is when we get our muscle contractions. So just to dive a little bit further into our ryanodine receptors, they do exist in 3 isoforms, R1, 2, and 3. As I mentioned, R1 is predominant in our skeletal muscles, R2 is primarily expressed in the heart and cardiac muscles, and then the R3 cells are found in the central nervous system. So patients who have mutations in the ryanodine 1 receptors or the R1 receptors have underlying diseases such as central core diseases, and in our case, what we're focusing on, malignant hyperthermia. So in the normal muscle, a patient who is not predisposed to MH, our ryanodine 1 receptors can be activated by this local increase in calcium, but it does have a mechanism to kind of halt and keep in check the amount of calcium that is released. And this is with cytosolic magnesium. So this will exert a potent inhibitory action on the channel and therefore help to regulate muscle contraction. So this way we don't have too much or too little. While in malignant hyperthermia, we have a higher rate of skeletal muscle calcium release because this is propagated by the mutations in our ryanodine 1 receptors. And in this case, there's too much calcium, and therefore the magnesium cannot overcome and help to ameliorate the excessive calcium effects. So this is why we get the muscle rigidity in malignant hyperthermia. So just to reiterate, in our MH crisis, the triggering agent induces a prolonged opening of our altered ryanodine receptors, which will lead to an uncontrolled release of calcium from our sarcoplasmic reticulum and therefore lead to ongoing muscle activation and rigidity. So the constant activation of the aerobic and anaerobic metabolism of this effect will result in increased oxygen consumption, which will also lead to the other effects of malignant hyperthermia. So this is where we'll see hypoxia, lactic acidosis, excessive production of CO2, as well as increased body temperatures. And when calcium is taken up into the sarcoplasmic reticulum and we have sustained muscle contraction, this will consume a large amount of ATP. And so when our ATP stores are depleted, this is also another mechanism behind muscle rigidity in malignant hyperthermia. And this most likely will lead to rhabdomyolysis in many of our patients. So one of the fulminant cases of malignant hyperthermia, you will see patients with excessive rhabdo. So some things to monitor for them would be their CPK, for instance. So now that I've spoken about the pathophys behind malignant hyperthermia, I want to talk a little bit about the agents that can cause this. So the largest offending agents are our volatile anesthetics. So these are halothane, isoflurane, desflurane, and sevoflurane. So these are all liquids at room temperature that require the use of vaporizers for inhalation administration. So when they refer to inhaled anesthetics, these are the anesthetics they're talking about. Nitric oxide is also another inhaled anesthetic, but that is the only inhaled anesthetic that has been proven to not cause malignant hyperthermia. So if one of our patients with a predisposition for MH needs to have the use of an inhaled anesthetic, nitric oxide could be a good option for them. So when patients are exposed to anesthetic gases, there is an excessive calcium release on its own in the skeletal muscle. So this will cause our patients to exhibit our malignant hyperthermia symptoms, which we kind of talked about previously. So they'll become hyperthermic, tachycardic, they'll have muscle rigidity, which is one of the very early and hallmark signs of MH, as well as hyperkalemia and metabolic imbalances. So all of the volatile inhalation anesthetics have the potential to induce an MH crisis, but it's very important to note, as I stated earlier, that exposure to these anesthetics does not inevitably lead to MH in our MH susceptible individuals. So it is a risk every time these individuals are in the presence of these type of anesthetics, but they can have exposure to them before actually having an MH crisis. What's important to note, though, about MH is that it's a very rapidly occurring syndrome, so it needs to be treated as an emergent situation. In most cases of MH, they actually occur in the 1 hour period immediately following the use of these triggering anesthetics. So if a patient is out of the OR in the PACU, that's almost the most opportune time to be able to catch malignant hyperthermia and properly treat it. One of the caveats to that, though, is that symptoms can actually be delayed for up to 12 hours. So there is a window of time where their disease can worsen. And for instance, many of the symptoms can develop in this extended time period. So that's why it's very important for these patients to have constant monitoring post anesthesia. So another medication that has been proven to cause malignant hyperthermia is succinylcholine, which is one of our depolarizing muscle relaxants, though the trigger potency of succinylcholine has been unclear. In the study I will talk about on the next slide, it actually shows that there's a relationship between the use of both succinylcholine and volatile anesthetics and the propensity for them to cause an MH reaction. There is a key sign, though, of a succinylcholine-induced malignant hyperthermia, and this is something that's called masseter muscle rigidity. So what this is, it's a severe sustained contraction of the jaw muscles that may be observed after the administration of succinylcholine. So if you have an anesthesiologist or a nurse who's very familiar with these medications, and they see that a patient post-succinylcholine develops this very severe muscle contraction in the jaw and jaw rigidity, that can be a sign of malignant hyperthermia from the succinylcholine use. So now moving on to the study, we'll be looking at malignant hyperthermia in Canada. So this looked at the characteristics of index anesthetics in 129 malignant hyperthermia susceptible probands. So susceptible probands just means patients who have the mutations in those ryanodine receptors that we spoke about earlier, and therefore have a higher risk of developing MH. Now, because this is such a rare disease, this study looked at patients between 1992 and 2011, so they could have an adequate amount of power to make conclusions from this study. So what did the study look at? So this was a retrospective study that looked at 129 patients who were survivors of adverse anesthetic reactions. What they found was that an overwhelmingly amount of patients, so 61.2%, were young males who were affected by MH, which just goes back to the beginning of our presentation where we find that this is the most vulnerable group to report an MH crisis. Now, of these patients, 13% of them had prior anesthesia that did not cause MH, which also goes into the fact that this is not a constant event, that it's very rare, and even if people are susceptible, they may not experience an MH crisis every time. Some things to look on were that the anesthetic triggers used were volatile only, succinylcholine only, or they used a combination of both our volatile anesthetics as well as succinylcholine. The volatile anesthetics are there for your reference on the slide. But another point that was made was that there was no significant difference in the duration of anesthetics between the volatile only, the succinylcholine only, and both the combination group, which meant that even though that the duration of these anesthetics were all the same, so duration of anesthesia does not increase or decrease a patient's risk for MH. So the main point of the study that I want to drive home will be on the next two slides in these charts. So for this chart, I just want to call attention to the top part here. So these are the anesthetic triggers that were used. As you can see on the third line, our volatile anesthetics actually were the most harmful in patients who were predisposed to malignant hyperthermia. So there was a 45% risk of these 129 patients going into an MH crisis using just the volatile anesthetics alone. And as you could see on the top here, that succinylcholine alone had the least incidence at 15.5%. And so if patients are exposed to succinylcholine and have MH predisposition, they have a less chance of actually going into an MH crisis, but that doesn't mean that this is a medication that should be used. It's actually recommended. There's a society called MHOUSE. They're the Malignant Hyperthermia Association of the United States. They're the ones who make all the recommendations and guidelines for the treatment of malignant hyperthermia. And their recommendation is to avoid all of these triggering anesthetics in patients who have any type of known predisposition to MH. So in these cases, we would want to use some of our other anesthetics. If patients need a neuromuscular blocker, both rocuronium and vecuronium were proven to be safe in patients with MH predisposition. So even though the use of succinylcholine has a lower incidence, it should not be the drug of choice. Moving on to the next slide. This is probably the most important slide for us to focus in on. And this is the fact that dantrolene, which is our reversal agent for malignant hyperthermia, its administration and the risk of complications is directly related. So as time goes on, if you have not administered dantrolene, the risk of complications increases exponentially. So as you could see on the graph, if a patient has not gotten the reversal agent within the first hour, they almost have 100% risk of complications from the malignant hyperthermic crisis. So it just goes to show that the time to administration is very important in this disease state. And because it is so rapidly evolving, it's important to know kind of the triggers and what to look out for patients who are having an MH crisis. So just to review what was found in this study, so there was, again, a 15.5% incidence of reactions of MH that were triggered by succinylcholine. But most importantly, the increased complication rates were associated with an increased time interval between the first adverse clinical sign and dantrolene treatment. So this study really emphasized the need for early diagnosis and rapid administration of our treatment agent in patients who are experiencing MH crises post-anesthetics. So now that we have some background on what malignant hyperthermia is, I want to go into the signs of malignant hyperthermia and how to recognize this as a clinical event. So these are some of the signs of malignant hyperthermia. The most common being muscle rigidity, tachycardia, as well as hyperthermia. What's important to note, though, is that hyperthermia is not the first sign to occur. The increase in temperature can actually occur much later in the syndrome. So you really want to look out for some of these other signs before diagnosing a patient with MH. So this chart kind of helps to divide the signs between early, developing, and late. So our early signs are listed here on the left. Elevated carbon dioxide is actually the most sensitive early marker for malignant hyperthermia. So post-anesthesia, if a patient comes in and you see that they have an elevated end-tidal CO2, that would be the most sensitive marker for a possible MH crisis. We also see muscle rigidity and tachycardia very early as well. So those are just things to look out for. The developing signs include our acidotic state and our temperature rise. Now, the temperatures in malignant hyperthermia can get extremely high, and I'll focus on those values on the next slide. And lastly, our late signs are more of our severe outcomes. So our increased CPK, which will lead to rhabdomyolysis, patients can develop coagulopathy, and more severely, they can develop cardiac arrest. So for our clinical symptoms, there are some instances where there are abortive cases of MH that just have mild or moderate symptoms. And these are usually the cases that are caught early on and they're given our reversal agent much earlier. But if that's not the case, these can blow into full fulminant MH crises, which have severe skeletal muscle hypermetabolism and rhabdomyolysis. Now, focusing on the temperature can actually increase at a rate of 1 to 2 degrees Celsius every 5 minutes and can reach or even exceed 43 degrees Celsius. And this is over 110 degrees Fahrenheit. So many of these patients at this point will develop some type of brain injury. Unfortunately, they could go into status epilepticus. So there's a lot of late signs that can occur due to the temperature rise. Also, almost half of our patients who are in MH crisis will develop arrhythmias or types of muscle reactions. These arrhythmias are usually secondarily to the acidosis and the hyperkalemia that is occurring in our MH. And the progression of MH can actually result in acute renal failure as well. But what's really important to note is that our end stage of our fulminant MH crises can be characterized by multi-organ failure and circulatory collapse. And these ultimately will be the worst outcomes for our patients. Now, even though we won't be diagnosing patients with malignant hyperthermia, it is important to note that there are many other differential diagnoses that can go along with MH. MH is a very difficult syndrome to recognize and to diagnose. And some of the symptoms that are occurring in MH are very similar to those that are listed here on the screen. So specifically, I want to focus in on serotonin syndrome. That's a rare, but also a common syndrome that we may see in the hospital. Now, just something to differentiate between serotonin syndrome and malignant hyperthermia is the way our muscles are reacting. So in MH, we have, again, this classic muscle rigidity, while in serotonin syndrome, we may have muscle clonus, which is actually like the loss of control of our muscles. But otherwise, many of the symptoms are very similar. They become hyperthermic, tachycardic. So it is important to note that even if malignant hyperthermia is on the differential, you should be looking out for any of these other causes that could be leading our patients down an unruly path. So now we're going to get into the outline and the management of what to do with a patient in malignant hyperthermia. So we have acute treatment that we want to do right away. The first would be to stop our triggering agent. Now, many of these patients may still need to have anesthesia or some type of sedation. So this is when you would want to administer the non-triggering anesthetics. So as I said before, you could use rocuronium or vecuronium, as well as other agents like ketamine and propofol. So just some things to keep in mind. These agents have not been proven to cause malignant hyperthermia. Next, and most importantly, we want to administer Ryanodex. So Ryanodex is the brand of dantrolene that we carry here at Stony Brook. And I'll be talking about this for the remainder of the presentation in just a few moments. And then lastly, we want to apply internal and external cooling. I'll focus a little more in depth about that at the end, but this is very important because our patients can have such high temperatures. We want to make sure to cool them down appropriately so their bodies can try and fight this reaction as well. So now speaking about dantrolene, we have both Dantrium and Ryanodex. These are the two brand names and the two forms of dantrolene that are available. Now, Ryanodex here at the bottom, which is bolded, is the formulation that we have at Stony Brook. And the main reasoning is due to the way that this medication is prepared. So if you see the older formulation Dantrium, it's a 20 milligram vial that must be reconstituted with 60 milliliters of sterile water for injection, as opposed to Ryanodex, which is a 250 milligram vial that only needs to be reconstituted with 5 milliliters of sterile water for injection. Now, dantrolene is a weight-based dose. So if you have, let's say, a 100 kilogram patient, if you're using the older formulation of Dantrium, that's an excessive amount of volume that must be given, which makes Ryanodex a lot more appealing because we can give higher doses with less volume. And dantrolene is also a vesicant. So if we're pushing a large amount of volume in, let's say, a not so stable IV line, we may cause our patients to extravasate, and therefore they're just having another problem that they could have avoided. So now we'll just be talking about Ryanodex for the rest of the presentation. So Ryanodex is a postsynaptic skeletal muscle relaxant. This acts directly on the skeletal muscle by interfering with the release of calcium from the sarcoplasmic reticulum. And by doing this, it's preventing and reducing the increase in calcium that activates our acute hypermetabolic processes that are associated with malignant hyperthermia. So if you recall from the beginning of the presentation, I spoke briefly about our normal ryanodine receptors that when they are causing calcium release, they're being monitored by magnesium. Magnesium is holding the calcium channel in a closed formation, so no more calcium can be released. If you think of Ryanodex like that, that's how it's working. Now, it's not magnesium, but it works in the same way by stabilizing the calcium channels. So therefore, we're suppressing the dysfunction that's occurring in malignant hyperthermia. Now, Ryanodex is a weight-based drug, so it's given at 2.5 milligrams per kilogram rapidly. It's usually given over at least 1 minute, and this is through a large bore IV, again, just because of the risk of extravasation. Now, if the signs and symptoms of MH persist, you want to repeat this dose until the signs are actually reversed. So you can give this medication up to a cumulative maximum dose of 10 milligrams per kilogram, but there is a caveat to this. There's been studies that have shown that some patients may actually require up to 30 milligrams per kilogram of Ryanodex to stop the symptoms of malignant hyperthermia. And the way Ryanodex works is the symptoms of malignant hyperthermia, if reversed, should stop almost immediately after the Ryanodex is given. The onset of action is almost 1 minute or less. So it is a very rapid acting medication. Just to point out, though, that there are some adverse reactions that have been seen with Ryanodex. These include skeletal muscle weakness, dyspnea, respiratory muscle weakness, as well as decreasing inspiratory capacity. Now, this also kind of goes into the risk versus benefit of giving Ryanodex. Now, because we know that the administration of early Ryanodex has better outcomes for our patients, you need to take into the fact that the side effects of Ryanodex compared to the progression of MH, they're not nearly as bad. So if a patient is suspected to have MH, according to that mHouse organization that I mentioned earlier, their recommendation is to administer this medication as soon as possible. But something to keep in mind is the pregnancy category associated with Ryanodex. So it's an FDA category C drug for women who are pregnant. We have to look at the risk versus benefit then of what to do if a pregnant woman is in malignant hyperthermia after exposure to set anesthetics. So the recommendations are actually to give dantrolene. We do know that it crosses the placenta and that there are side effects in the neonate, but this expected side effects of this medication on both the mother and the child are not nearly as fatal as if the malignant hyperthermia were to continue and to progress. So just something to keep in mind if that's ever a situation that occurs. Now, lastly, I just want to focus on some additional measures that we want to take in patients who have malignant hyperthermia. So as mentioned earlier, many of these patients can have metabolic acidosis. So in these cases, we would want to administer sodium bicarbonate, and it's given at 1 to 2 milliequivalents per kilogram. And many of these patients, as I mentioned before, have to be strictly monitored while they're going through this crisis, and actually up to 24 hours afterwards. They have a lot of kind of labs that are being drawn to help monitor the progression of their disease. ABGs, or arterial blood gases, being one of them. So that's a case where you would be able to monitor the acidic environment of the patients and therefore administer sodium bicarb as necessary. One of the most important medications or steps to take for a patient in MH, other than the administration of dantrolene, is actually to cool the patient. So we want to apply ice if the core temperature is over 39 degrees Celsius, which in most cases of MH, the temperature will be well above this. This includes using ice packs as well as infusing cold IV saline. So this is something that I thought was very interesting, but it was proven that if you administer cool IV saline, it helps to decrease our core temperature and therefore will help our patients improve in their MH crises. Now, once our temperature of the patient has been adequately cooled to less than 38 degrees Celsius, this is when we would want to stop these cooling efforts to therefore let the patient try and fight the syndrome on their own. Now, since MH is a very, again, rare condition, I just wanted to briefly mention that there are MH carts available in the hospital. They're located in the OR as well as the AMSurge units. And on these carts, we have the dantrolene kits, as well as a small refrigerator that also contains the cool IV saline. Because these are two of the most important medications to give, we want to make sure that they're readily available if this crisis occurs. So now that we've gone over the background of MH, since it is such a complicated syndrome, I just wanted to briefly go over a patient case and see the steps that you would take for the following patient. So we have a patient, DM, who is an 18-year-old male that arrives in the PACU status post-surgical intervention for a torn ACL. He's noted to have muscle rigidity, as well as becoming tachypnic, as well as tachycardic. His blood pressure is 154/90, and his temperature, which was 37 degrees Celsius pre-op and 30 degrees Celsius at PACU admission, has now jumped to 40 degrees Celsius, or 104 degrees Fahrenheit. He has no significant prior medical or surgical history. And when you're reviewing the MAR, you see that he received isoflurane for general anesthesia. Now, if you guys want, you could just write in the chat if you see anything in this patient case that may predispose this patient to a malignant hyperthermic crisis. Yes, so muscle rigidity is one of the key and most severe symptoms of malignant hyperthermia, as well as being a young male. So as we talked about earlier, our adolescent male patients are at the highest risk if they are predisposed, and muscle rigidity is one of the most classic symptoms of MH. Having this high temperature as well as receiving the isoflurane, which is a volatile anesthetic, are all risk factors for developing MH. So basically, this is the most straightforward case you would see of malignant hyperthermia. Everything in this case is directly related to the development of this syndrome. So if a patient would present like this, we would want to administer our Ryanodex as quickly as possible, as well as to cool the patient with our cool saline and continue to monitor them for up to 24 hours. So just some final things to take away. Because this, again, is a kind of a complex syndrome, just to touch on the main points, is that there is a genetic predisposition that can put our certain patients at risk for MH. The exposure to volatile anesthetics and or our neuromuscular blocker, succinylcholine, can trigger these MH crises. And lastly, and most importantly, the one thing I want you guys to take away today is that the time to prognosis and treatment with Ryanodex is essential when treating malignant hyperthermia. And this prompt treatment will give our patients the best outcomes. So I just want to see if anyone has any questions, and also thank you guys for attending the CE tonight. Hi, Kelly, that's a great question. So like we said, yes, the dose of dantrolene is 2.5 milligrams per kilogram. The max dose is usually a cumulative dose of 10 milligrams per kilogram. But as I mentioned before, in some cases, the patients may actually need up to 30 milligrams per kilogram. So depending on if the symptoms are still progressing and if the patient has not yet come out of the malignant hyperthermic crisis, they could need up to 30 milligrams per kilogram. And I do believe that dantrolene is based on the actual body weight. I'm not 100% sure though, so I will look that up so I can give you the most correct answer. But thank you for that question.